Welcome, colleagues. Let's begin by establishing the clinical definition of myasthenia gravis, or MG. At its core, MG is a chronic autoimmune disorder localized specifically to the neuromuscular junction. There are two hallmark characteristics you must recognize: fluctuating skeletal muscle weakness and pathological fatigability. Unlike static weakness seen in other conditions, MG is dynamic. Muscle power diminishes significantly with repetitive use or as the day progresses. This weakness classically follows a specific distribution. It primarily targets the ocular muscles, the bulbar muscles responsible for speech and swallowing, and the proximal muscles of the limbs. When we define MG, we are describing this precise combination of immune-mediated dysfunction at the neuromuscular junction and its unique pattern of fatigable weakness across these key muscle groups. Understanding this clinical triad is fundamental to recognizing the disease presentation.
Moving to the etiology and pathophysiology, myasthenia gravis is essentially an antibody-mediated autoimmune attack on the postsynaptic neuromuscular junction. We see a profound association with the thymus. Roughly 70% of patients have thymic hyperplasia, and up to 15% have a thymoma. It also frequently co-occurs with other autoimmune disorders, such as hyperthyroidism or rheumatoid arthritis. Pathophysiologically, the primary culprits are IgG1 and IgG3 antibodies targeting nicotinic acetylcholine receptors. These antibodies trigger receptor degradation, block the acetylcholine binding site, and induce complement-mediated damage to the junctional folds. This triple threat reduces the density of functional receptors, causing a diminished end plate potential that fails to trigger a muscle fiber action potential. While AChR antibodies are most common, in seronegative cases, we often find antibodies directed against muscle-specific kinase, MuSK, or LRP4, highlighting the molecular diversity behind this synaptic failure.
Now, let's focus on the clinical presentation. The hallmark of myasthenia gravis is painless muscle weakness, characterized by marked fatigability. Most patients first notice ocular symptoms, specifically ptosis and diplopia, which characteristically worsen as the day progresses. The weakness is typically proximal, making everyday tasks like climbing stairs or brushing hair increasingly difficult. A key diagnostic clue is diurnal variation. Symptoms are typically mildest in the morning or after rest, but peak in the evening. Importantly, despite the motor weakness, deep tendon reflexes remain normal, and there are no sensory deficits. We can confirm this fatigability at the bedside by eliciting sustained muscle contraction, for example, observing for increasing ptosis during a prolonged upward gaze. This pattern of fluctuating, effort-dependent weakness is central to your clinical diagnosis.
Moving on to the diagnostic criteria, establishing a diagnosis of myasthenia gravis requires a combination of clinical, serological, and electrophysiological findings. First, we must document objective evidence of fatigable weakness during the clinical examination. This is the hallmark of the disease, where muscle strength perceptibly declines with repeated effort. Second, we look for serological confirmation. We are specifically testing for the presence of anti-AChR or anti-MuSK antibodies, which provide high specificity for the diagnosis. Third, we require electrophysiological evidence of a neuromuscular transmission defect, typically demonstrated via repetitive nerve stimulation or single-fiber EMG. Finally, we consider the patient's response to acetylcholine esterase inhibitors. A clear, objective improvement in strength following administration further supports the diagnosis. By integrating these four pillars, clinical fatigue, positive serology, electrophysiological defects, and pharmacological response, we can accurately diagnose and classify myasthenia gravis in our patients.
Now, let's look at the diagnostic workup for myasthenia gravis. Our first-line investigations begin with serum anti-acetylcholine receptor antibody titers. We also include thyroid function tests to rule out associated Graves' disease and a CT of the chest to screen for Thymoma. The gold standard for diagnosis is single-fiber electromyography, or SFEMG. This is our most sensitive test, specifically looking for increased jitter. Supporting these are several physiological tests. Repetitive nerve stimulation typically shows a classic decremental response. While the tensilon or Edrophonium test was historically common, it is rarely used today due to the risk of serious bradyarrhythmias. Instead, we often use the bedside ice pack test for patients with ptosis. By cooling the eyelid, we slow the enzymatic breakdown of acetylcholine at the neuromuscular junction, resulting in a temporary improvement. This systematic approach ensures both diagnostic accuracy and patient safety. Moving to management, our strategy integrates symptomatic relief, long-term immunosuppression, and surgical intervention. For symptomatic control, pyridostigmine, a long-acting acetylcholinesterase inhibitor, is our first-line agent. If symptoms persist, we introduce prednisolone. However, steroids must be started at low doses in a hospital setting, as they can cause a transient worsening of symptoms. To maintain long-term stability, we employ steroid-sparing agents like azathioprine, mycophenolate mofetil, or cyclosporin. Surgically, a myectomy is mandatory for all patients with a thymoma. We also consider it for patients under 60 with generalized AChR-positive MG to improve remission chances. Finally, be alert for a myasthenic crisis, defined by respiratory failure, specifically an FVC below 15 milliliters per kilogram, and severe dysphagia. This is a medical emergency requiring ICU transfer and plasmapheresis or IVIG. Critically, you must avoid magnesium sulfate and aminoglycosides, which can precipitously worsen the crisis.
Let's focus on the high-yield pearls for your MRCP. When investigating, remember, single-fiber EMG is the most sensitive tool, but anti-AChR antibodies are your most specific initial test. Be wary of exacerbating medications, specifically beta blockers, aminoglycosides like gentamicin, procainamide, quinine, and lithium. At the bedside, the ice pack test is a classic maneuver. Cooling the eyelid for 2 minutes inhibits acetylcholinesterase, which visibly improves ptosis. Regarding management, thymectomy is recommended for younger patients, typically under 60, with generalized disease to induce remission, even if no thymoma is present. However, you must always perform a CT chest for every new diagnosis to rule out a thymoma, found in 15% of cases. Finally, differentiate MG from Lambert-Eaton. In LEMS, unlike myasthenia, weakness actually improves with exercise, and reflexes are typically absent. Keep these distinctions in mind for the exam.
And that brings us to the end of today's session. I hope this has been a valuable and clear overview. To truly consolidate this knowledge, I encourage you to take the next step. Visit our online platform at mrcpelite.com. There, you can create a free account instantly. You will find a structured slideshow summarizing today's topic, followed by 2 dedicated self-assessment tests. One for MRCP Part 1 and another for MRCP Part 2, each containing 20 focused questions. Take these tests to actively engage with the material. The platform will provide you with an immediate score and, most importantly, detailed, illustrated explanations for every answer, helping you fix the information firmly in your mind. To supercharge your preparation, consider upgrading to a pro user subscription. This unlocks powerful tools, unlimited disease-specific search queries, unlimited access to high-yield exam pearls, unlimited interactive flashcards, and most critically for your exam readiness, full exam board access with 50 question banks for every MRCP subject, and realistic mock exam simulations for both Paper 1 and Paper 2 that closely mirror the actual exam environment. For a limited time, we are running an exclusive offer. Gain all these pro benefits for just $50 for a full year, a significant saving from the standard price of $250. So, head to mrcpelite.com now. Start with your free account, test yourself, and explore how the Pro upgrade can transform your revision journey. Thank you for your time and all the very best for your studies.